And dear friends, we shall start our lecture, and topic of today's lecture, arterial hypertension. I want to introduce the head of our department, Dr. Yemelyanov Dmitry Nikolaevich.
Okay, morning guys. We continue our lectures in cardiology, and today we'll talk about arterial hypertension. So, arterial hypertension. Worldwide prevalence estimates for hypertension maybe as much as 1 billion individuals. You know, we have only 7 billion individuals on our planet, and 1 billion suffer from arterial hypertension. This is the most common cardiological problem. The most common cardiological problem. The prevalence of hypertension increases with advancing age to the point where more than half of people aged 60 to 69 years old are approximately 3/4 of those aged 70 years and older are affected. So it means that this is extremely common disease, and this is disease of aged persons. Now, this is disease of aged persons. In populations, blood pressure fits a normal distribution, but the attendant risk of heart diseases and stroke increase covariantly with increasing levels of blood pressure without any obvious breakpoint. So what we are talking about? This chart shows us distribution of blood pressure in humans population. And you see, of course, most of people, they have normal blood pressure, but there are a lot of people with blood pressure higher than normal, with hypertension. And this line, this is risk of cardiovascular death, risk of dying from myocardial infarction. And what you can see, that with rise of blood pressure, we have a rise of risk. And you see, if someone has blood pressure 160 systolic and more, he has 6 times more chance to die from cardiovascular problems compared with person with normal blood pressure, with blood pressure leveled 110 millimeters hydroargyrum systolic. Beginning at 115 systolic and 75 millimeters hydroargyrum diastolic blood pressure, for every 20 millimeters hydroargyrum systolic or 10 millimeters hydroargyrum diastolic increase in blood pressure, there is a doubling of mortality from both ischemic heart disease and stroke. So again, if someone has blood pressure 135, this is 20 millimeters more than 115. It means that he has 2 times higher risk of dying, of mortality from heart disease and stroke. If someone has blood pressure 155 systolic, 155 systolic, it means that he has 4 times higher risk. Now this is what I showed you on the chart on previous picture. Based on the results of randomized clinical drug trials, hypertension is defined as a blood pressure of 140 systolic by 90 diastolic millimeters hydroargyrum or greater, because this is the value above which the benefits of treatment appear to outweigh the risks. So again, remember these numbers: 140 systolic, 90 diastolic. This is a level of blood pressure when we can say that someone suffers from arterial hypertension. 140 by 90 and more, this is patient with arterial hypertension. But you can say that you know that blood pressure, for example, 130, already bring 2 times risk of dying from cardiovascular disorders. Why 140 by 90? You know, the idea is following. What does it mean disease? If we say that someone suffers from in our example, arterial hypertension, it means that we must start treatment. We must start giving some remedies, some drugs, some pills to our patients. And you should realize that no benign remedies, no benign treatment. And all treatments bring some risk. And we start treatment again when benefits of treatment appear to outweigh the risks. No, this is the same as for other examples. For example, if we talk about, I don't know, diabetes mellitus, normal level for glucose is 5.5, but disease when sugar become 6.1. So we have some gap, because normal value and value we can tell that this is already disease. This is already disease. But the most important, remember these numbers, 140/90 and higher, this is already arterial hypertension. Prehypertension. Prehypertension defined as a blood pressure 120/139 by 89 millimeters hydroargyrum, and individuals with blood pressure in this range are twice as likely to progress to hypertension compared with individuals with lower blood pressures. It means that these levels of blood pressure, this is not disease, but if someone has such levels of blood pressure, it means that he has a risk of developing of hypertension in future compared with persons who has normal blood pressure, lower blood pressure. Next idea, if you say that someone suffers from arterial hypertension is not a disease, it's a syndrome. It's the same if you say that someone suffers from fever. Fever is not a disease, it's a symptom, syndrome. But causes for arterial hypertension may be different. We have two main causes for arterial hypertension. One is known as essential hypertension or primary hypertension. Essential hypertension, primary hypertension, sometimes we refer as hypertensive disease. And second group of patients, they suffer from secondary hypertensions. So again, we have essential or primary hypertension and secondary hypertension. What does it mean? What is the difference? The great majority of patients with hypertension, about 95%, have primary elevation of blood pressure. It means that this is essential hypertension. Actually, cause not known. Examining patient, we can't find the reason, we can't find the cause, why blood pressure rise. We don't know. And in this case, we tell that this is essential or primary hypertension. And this hypertension can be ameliorated only by lifelong pharmacological therapy. It means that if someone suffers from essential hypertension, we can do one thing. We can give this patient remedies which can decrease elevated blood pressure. And patient should take these pills a long life, till the final days of his life. We can't cure, but we can control such kind of hypertension. We can't cure, but we can control hypertension. No, essential hypertension has a multifactorial etiology. I told you that we don't know one reason, one cause, why blood pressure rises in people. But we know some predisposing factors. No, which factors? No, first of all, genetic factors. No, blood pressure tends to run in families, and children of hypertensive patients tend to have higher blood pressure than age-matched children of people with normal blood pressure. So most of, especially chronic disorders, they have some genetic predisposition. That's why, again, we don't know exactly what genes cause elevation of blood pressure. Actually, some group of genes detected, but this is not only one. But what we know, yes, if parents suffer from hypertension, for his children's risk to produce hypertension in future is high compared with people with relatives, with his mother and father with normal blood pressure. Fetal factors. Studies have consequently shown a relationship between low birth weight and subsequent higher blood pressure. We don't know why, but actually it was shown in different studies that low weight on birth, low birth weight predisposed to development of arterial hypertension in future. Environmental factors, obesity. Fat people have higher blood pressure than thin people. This is fact, this is for sure, and that's why we have a lot of hypertension among obese patients, among obese people. Alcohol intake. Most studies have shown a close relationship between the consumption of alcohol and blood pressure levels. However, subjects who consume small amounts of alcohol seem to have a lower blood pressure level than those who consume no alcohol. It does mean that we can say that alcohol, this is some kind of treatment for essential hypertension. No, this is a fact. And again, if we talk about consumption of high doses of alcohol, this is risk factor for development of arterial hypertension. Sodium intake. High sodium intakes have been suggested to be an important determinant of blood pressure, differences between and within population around the world. Now, populations with high sodium intake have high average blood pressure than those with lower sodium intake. No, there is some evidence that high potassium diet can protect against the effects of high sodium intake. No other words, in some populations, for example, in Russia, people like a lot different salty vegetables, use a lot of salt, and this may predispose to elevation of blood pressure. Stress. Whilst acute pain or stress can rise blood pressure, it has been difficult to study the relationship between chronic stress and blood pressure, and therefore it remains uncertain where the chronic job strain can be implicated in the pathophysiology of essential hypertension. In other words, it wasn't proven that patients in stress, they suffer more from arterial hypertension. What else we know about essential hypertension? We know some humoral mechanisms which may be involved. For example, autonomic nervous system, as well as renin-angiotensin, natriuretic peptide, kallikrein-kinin system, plays a role in the physiological regulation of short-term changes in blood pressure and has been implicated in the pathogenesis of essential hypertension. However, this is not convincing evidence that any of these systems is directly involved in the maintenance of hypertension. Now again, what we are talking about, everyone knows that epinephrine raises blood pressure. Suprarenals, in case of stress, release epinephrine, and epinephrine cause elevation of blood pressure. But it wasn't proven that in people with arterial hypertension, they have high levels of epinephrine. And we can tell the same about other systems which play some role in elevation of blood pressure, like renin, angiotensin, natriuretic peptide, and so on. It wasn't proven. Insulin resistance. Association between diabetes and hypertension has long been recognized, and syndrome has been described of hyperinsulinemia, glucose intolerance, reduced levels of HDL cholesterol, hypertriglyceridemia, central obesity, all which are related to insulin resistance in association with hypertension. And this association is known as metabolic syndrome or syndrome X, and is a major risk factor for cardiovascular diseases. Okay, we'll talk about this when we'll talk about diabetes, but what you should know, remember I told you that usually hypertension come together with obesity. And the same, it go together with diabetes, with changes in cholesterol levels, and all this known as X syndrome. That's why we can find hypertension in high chance among obese people, among people with diabetes mellitus. So this is major risk factor for cardiovascular disease. So, secondary hypertension. Secondary hypertension, more easy to understand, easy for understanding. This is secondary hypertension in which blood pressure elevation is the result of specific and potentially treatable cause. So it means that we can find cause. We can find why blood pressure rises in this person. And actually, in most of cases, this is renal diseases. 80% of secondary hypertension, this is patients with renal disease. No common causes: diabetic nephropathy, chronic glomerulonephritis, renovascular diseases. Hypertension can in itself cause or worsen renal disease. And mechanism of this blood pressure elevation primarily due to sodium water retention. No, although there can be inappropriate elevation of plasma renin levels. So again, remember physiology. In kidneys we have renin, we have production of renin. We have juxtaglomerular apparatus. This is specific cells which produce renin. When these cells produce renin, when kidneys experience some kind of ischemia, when kidneys experience lack of oxygen, lack of blood, usually it's happened when we have drop of blood pressure. You know that kidney is a filter. To filtrate something, we need some pressure to push the water pass through this filter. And if blood pressure decrease, kidney can't normally filtrate urine. As a result, they release renin, and renin increase blood pressure through renin-angiotensin-aldosterone system. And it works when it's normal physiological condition. But just imagine that patient has some renal disorder, inflammation of kidneys, for example, nephritis. Inflammation causes problems with blood supply. It causes damage of vessels, damage of glomerulus. As a result, we have local ischemia of kidneys. Kidneys know nothing about what happened with entire body, with central blood pressure. Kidney experiencing lack of oxygen, they just start producing renin, and it results in rise of systemic blood pressure. And in this case, we tell that hypertension is just a symptom of renal disorder. And in case of, for example, acute or chronic nephritis, glomerulonephritis, one of symptoms is rise of blood pressure. If you know cause, you can start treatment of glomerulonephritis, and if you cure glomerulonephritis, hypertension disappear. Endocrine causes. Different hormones regulate blood pressure. And most of these hormones increase blood pressure. Now, we discussed already about epinephrine, which can cause rise of blood pressure. We talk about glucocorticoids, which also cause rise of blood pressure. Aldosterone can cause rise of blood pressure. And that's why if we have some endocrine pathology with rise of production of one or another hormone, it may cause arterial hypertension. Now, for example, Cushing's syndrome. Cushing's syndrome, this is overproduction of glucocorticoids. If we have overproduction of glucocorticoids, we have rise of blood pressure. We cure a patient with Cushing's syndrome, remove this tumor which produces these glucocorticoids, and blood pressure remains normal. Again, becomes normal. Cardiovascular cause. Cartation of the aorta. What means cartation? Cartation is some narrowing of aorta, which may be congenital, which may be due to other reasons. And what happened in case of cartation of aorta? Just imagine, huge vessel, the biggest vessel in our body, aorta. And if we have some cartation, some narrowing of aorta, what happens? Above this narrowing, we have high blood pressure. Below this narrowing, we have low blood pressure. And to detect this, it's very easy, because normally we measure blood pressure on arms. But don't forget that it's also possible to measure blood pressure on legs. And if blood pressure on measured on arms becomes higher than blood pressure on legs, it tells us about cartation of aorta. It's also possible to treat surgically, for example. Drugs. Many drugs have been shown to cause or aggravate hypertension or interfere with response to some antihypertensive regencies. Now, for example, steroids. I told you that Cushing's disease, this is overproduction of steroids, cause secondary hypertension. But some of our patients, they need to take steroids as remedies, and they may suffer from rise of blood pressure. It will be due to steroids, it will be due to hormones, or even contraceptive pills. It was shown that can cause rise of blood pressure in some women. Now, in this case, just stop giving these remedies and blood pressure normalize. What about clinical picture, clinical manifestation? You know that hypertension has been termed the silent killer. Silent killer. Why? Because in most of cases, no complaints, no clinical signs, and is a chronic illness with a long asymptomatic phase that, if undetected and untreated, silently damages the heart, brain, kidneys. So the main problem is not numbers. What is the numbers of blood pressure? 140, 160. The main problem that this rise of blood pressure may cause damage of inner organs. And that's why damage of these inner organs, and which organs? Heart, brain, kidney, may cause actually patient death, that can even kill patients. Now, although headaches are common in patients with mild to moderate hypertension, episodes of headaches don't correlate with fluctuations in ambulatory blood pressure, but rather with a person's awareness of his or her diagnosis. So again, people believe that one of signs of blood pressure, this is headaches. Yes, in some people of hypertension, they may complain of headaches, especially morning headaches. Patient wake up with headache, and this is some heaviness in the head. This headache is not usually acute or severe. It usually disappears during daytime. That's why it may be as a sign of arterial hypertension, but not in all cases. Not in all cases. And you know that a lot of people suffer from headaches, dealing nothing with actually arterial hypertension. Effects of hypertension. What hypertension do? Why we consider hypertension is extremely serious disease? You know that number one killer in the world, this is cardiovascular disorders. Most of people in the whole world die from cardiovascular disorders. Myocardial infarction, stroke, and people believe that the most important risk factor for cardiovascular disorders is, for example, cholesterol, high cholesterol levels. But actually, number one risk factor for development of cardiovascular diseases, this is arterial hypertension. We can say that half of people who die from myocardial infarction, for example, they die because of arterial hypertension. In half of cases, arterial hypertension cause cardiovascular disorder, cause myocardial infarction, and patient die. That's why arterial hypertension increase in many times, in 2-3 times risk of dying from cardiovascular disorders, from stroke and from myocardial infarction. So patients with hypertension die prematurely. So this is the main problem, that they live less compared with persons without arterial hypertension. And the most common cause of death is heart disease with stroke, and renal failure also frequent. Again, hypertension kills persons. How? Due to heart disease, due to brain disease, stroke, and renal failure. What happened with the heart? Effects on the heart. Cardiac compensation for excessive workload imposed by increased systemic pressure is at first sustained by concentric left ventricular hypertrophy, characterized by increase in wall thickness. So again, what happened? What does it mean? We have high blood pressure. It means that aorta blood pressure is higher than normal, and left ventricle should pump blood into system with high blood pressure. Resistance increase, and to do this, to pump blood, left ventricle should work with high force. We have overload of left ventricle with pressure. What happens if we have overload of muscles? If we have overload of muscles, no, muscles try to increase in size. We have hypertrophy of muscles. In our case, we have hypertrophy of left ventricle. We have hypertrophy of left ventricles. Now, ultimately, the function of this chamber deteriorates, cavity dilates, and the symptoms and signs of high heart failure appear. Again, during first years, left ventricle becomes bigger, stronger, and pump blood into system with high blood pressure. Because it's not good. because actually this overload leads to the fact that heart has no rest, and this overload for the long time leads to dystrophy, leads to ischemia, and finally left ventricular fail. Cavity dilates, increase in size, and we have left ventricular failure. Heart tight, heart already can't pump blood to this system with high blood pressure, and symptoms and signs of heart failure appear. Patients start experiencing dyspnea, weakness, tiredness. Then we have already involvement of right ventricle. We have deposition of liquid in peripheral organs. We have peripheral edema. No, and we have patient with high level of heart failure, and patient may die due to heart failure. Patient may die due to heart failure. Angina pectoris may also occur because of the combination of accelerated coronary arterial disease and increased myocardial oxygen requirement as a consequence of increased myocardial mass. Again, big left ventricle, hypertrophic big left ventricle, can't need a lot of oxygen, needs a lot of blood. But coronary arteries can't provide sufficient amount of blood. Why? Because they can't grow and provide more oxygen and blood. And also, arterial hypertension causes damage of vessels and increase and accelerate development of coronary atherosclerosis. Coronary atherosclerosis. And we have coronary arteries affected with atherosclerosis and big ventricle, which needs a lot of oxygen. Of course, we have disbalance between demands of ventricles and ability of coronary arteries to provide such amount of oxygen. And clinically, we have angina. We have angina because angina, this is sign of ischemia, of cardiac muscles ischemia. On physical examination, the heart is enlarged, has a prominent left ventricular impulse. So enlargement of the heart, we discussed, we have hypertrophy, then dilatation. As a result, point of maximum impact PMI shift to the left and down. Left heart border also shift to the left. We can detect this by percussion, for example, and auscultation. Sound of aortic closure if accentuated. They may be okay. We remember when I told you about auscultation, that we can compare intensity of heart sounds in different points. And for example, if you compare intensity of second heart sound under aorta and pulmonary trunk, and you remember that second heart sound, this is closure of aorta and pulmonary trunk, and intensity of these sounds under aorta and pulmonary trunk should be equal. What happens if we have arterial hypertension? It means that pressure in aorta is higher than normal. It means that aortic valve closed with higher force, because this pressure in aorta close this valve rapidly with loud sound, and it means that intensity of this sound under aorta becomes higher compared with pulmonary trunk, compare with pulmonary valves which are not affected. And that's why we have accent of the second heart sound under aorta. ECG, electrocardiographic changes of left ventricular hypertrophy may occur. No, ECG substantially underestimates the frequency of cardiac hypertrophy compared with that observed with echocardiogram. Now again, what we can find on ECG, this is signs of left ventricular hypertrophy, the left ventricular hypertrophy. Which signs? Again, in chest leads, tall R's in V5, V6, and deep S in V1, V2. So we have signs of left ventricular hypertrophy. No evidence of ischemia or infarction may be observed late in the disease, and most death is due to hypertension, results from myocardial infarction or congestive heart failure. Again, I told you that people with hypertension, they die not because numbers is higher than normal. They die because we have affection of the heart, and finally we have myocardial infarction, or we have actually congestive heart failure. Nerve system, neurological effects. The second target for elevation of blood pressure, this is nerve system. Neurological effects of long-standing hypertension may be divided into retinal and central nervous system changes. Because the retina is the only tissue in which the arteries and arterioles can be examined directly, repeated ophthalmological examination provides the opportunity to observe the progress of the vascular effects of hypertension. So what we're talking about? You know the retina, eyes, the retina of eyes. This is, anatomists, they tell that retina or eyes, this is just piece of brain which are reachable for examination. Yeah? And that's why what happened with vessels of eyes with retina, the same happened with vessels in brain. And that's why when we examine eyes, retina, we can understand what happened with other vessels. So increasing severity of hypertension associated with focal spasms and progressive general narrowing of arterioles, as well as appearance of hemorrhages, exudates, papilledema, and these retinal lesions often produce blurred vision and even blindness, especially when the papilledema or hemorrhages of macula area. So again, what you should remember that actually damage of retina vessels can cause problems with vision or even blindness. Central nerve system. Central nerve system dysfunction also occur frequently in patients with hypertension. Now, what you should understand, what damage hypertension? Hypertension causes damage of vessels, because where is hypertension? This is in vessels. And you just imagine in some pipes we have very high pressure. What may happen? Just leakage, just destruction of these pipes. Now, the same happened with vessels. High pressure can cause damage of our pipes, of our vessels. So, what happened with vessels in central nerve system and what happened with central nerve system? Now, again, occipital headaches, most often occurring in the morning, among the most prominent early symptoms for hypertension. I told you that one of the first signs of hypertension, this is just headache. What else? Dizziness, lightheadedness, vertigo, tinnitus, and dimmed vision or syncope may also be observed. Now we talk about some central nerve system signs, like headaches, vertigo, dimmed vision, syncope, loss of consciousness, may be observed. But the most serious manifestations are due to vascular occlusion, the hemorrhage or encephalopathy. Finally, this damage of vessels, of brain vessels, may cause vascular occlusion or hemorrhage, which results in stroke, or encephalopathy. So, if we talk about severe consequences, acute damage of the brain, this is damage of vessels with cerebral infarction or cerebral hemorrhage. What is cerebral infarction? The same as happened with vessels of coronary vessels, because in case of hypertension leads to progression of atherosclerotic processes. Atherosclerosis, this is atherosclerotic plaques in vessels, which cause narrowing vessels, and then this leads to thrombosis of vessels. As a result, we have thrombosis and infarction. What is infarction? This is death of some tissues due to lack of blood supply. It may be myocardial infarction or brain infarction, depending where it's happened. And in case of brain infarction, we talk about actually ischemic stroke, the ischemic stroke. On the other hand, high pressure may cause hemorrhage, rupture of vessels in brain, and cerebral hemorrhage due to elevation of blood pressure or development of cerebrovascular microaneurysm. We'll talk about this actually damage of vessels and resulting in leakage of blood. Leakage of blood into brain tissue lead to actually severe hemorrhage, and we see also stroke. Clinically, ischemic stroke, hemorrhagic stroke look like the similar. Even patient avoids stroke. Hypertensive encephalopathy may develop. And hypertensive encephalopathy consists of the following symptom complex. This is severe hypertension, disordered consciousness, increased intracranial pressure, retinopathy with papillary edema, seizures, so loss of consciousness. No, pathogenesis is uncertain, but it probably not related to arterial spasm or cerebral edema. So what you should remember, hypertension may cause severe damage of the brain with patient disability even without stroke. So atherosclerotic lesions of the, what happened with kidneys? We talk about heart, we talk about brain. Now let's talk about kidneys, about third main target for arterial hypertension. So what happened with kidneys? Atherosclerotic lesion of the afferent and efferent arterioles and the glomerular capillary tufts are the most common renal vascular lesions in hypertension and results in decreased glomerular filtration rate, tubular dysfunction. Now again, we have damage of vessels. We have damage of vessels of brain. We have damage of brain. We have damage of coronary arteries. We have damage of heart. We have damage of kidney vessels. We have damage of kidneys. And what is the main function of kidney? Produce urine. This is cleaning function. If we have damage of vessels, and you know glomerulus is vessels, we have damage of kidneys. First, we have proteinuria, presence of protein in urine, microhematuria, and after that we have progression of kidney damage, we have development of kidney failure, and you see 10% of deaths caused by hypertension result from renal failure. So finally, if patient avoid myocardial infarction, if patient avoid even stroke, he will die from kidney failure. So hypertension kill persons for sure. One way, another way, but unfortunately untreated hypertension lead to patient death. Examination of patient. No, everyone can actually, I think you can measure blood pressure. You know how to measure blood pressure. And usually we use office blood pressure. Because blood pressure normally varies dramatically throughout 24-hour period, you know, blood pressure is very varying. Patient exciting, patient afraid of something, patient in stress, and his blood pressure immediately rise. Blood pressure rise in case of physical activity, and when patient at rest, blood pressure decrease. That's why, as blood pressure may change a lot during 24 hours, multiple readings on more than one occasions are required to obtain a clear picture of a person's unusual blood pressure. And for this reason, hypertension should never be diagnosed on the basis of a single elevated reading. So what we're talking about? You have a patient in your office, or you measure his blood pressure and find that he has elevated blood pressure. You can't write immediately arterial hypertension. What you should do? You should measure this blood pressure at least twice. Okay, to minimize variability in readings, blood pressure should be measured at least twice after 5 minutes of rest, with the patient seated, back supported, arm at heart level. Cuff should not be too small for the arm. Tobacco, caffeine should be avoided for at least 30 minutes. Most overweight adults require a large cuff, a large adult cuff, special cuff. So again, it should be at least 2 readings during one visit, and it should be at least 2 visits. So what does it mean? Okay, at the beginning of your patient examination, you find rise of blood pressure. Okay, talk with patient, examine him, and at the end of visit, measure blood pressure again and fix it. And then ask your patient, please visit my office in few days. And when patient will come to you, again, you should measure twice his blood pressure. And only if in all readings you have elevation of blood pressure, you can say that this is arterial hypertension. Again, you should fix this elevated blood pressure a few times. Only in this case you can say that this is arterial hypertension. Blood pressure. We can talk about stage of blood pressure or stage of hypertension. Blood pressure is staged as normal, prehypertension, or hypertension based on the average of 2 or more readings taken or 2 or more office visits. I told you about this. When a person's systolic, diastolic pressure fall into different stages, higher stage should apply. You see, according to this table, what we see? We have normal blood pressure. This is less than 120 by 80. We have pre-hypertension. This is 120, no, 139, not 20, 139, 80, 89. And I told you, what is hypertension? Hypertension, this is blood pressure more than 140 by 90. That's why stage 1, systolic 140, 159, diastolic 90, 99, stage 2. No, you know, in Europe and United States, now they use 2 stages. They tell that if blood pressure higher than 160 by 100, this is already second stage. But in our country, in Russia, we still use 3 stages. And second stage is 160, 160, 179, and diastolic pressure 100, 109. And third stage is when blood pressure more than 180 by 110. Now, why in Europe and United States they decided that it's enough to have 2 stages? Because blood pressure above 160, this is already so dangerous that they tell no need to make other staging, because this is people with high risk. This is people with high risk for development of different complications. Now, few pictures. This is actually retina of patient with arterial hypertension. What you can see, you know, very thin vessels. This is arteries. They're in spasm because in high pressure they become spastic, trying to avoid rupture due to high blood pressure. All veins, these white vessels, this is veins. They overfilled with blood. What else we can see? You see these red spots. This is hemorrhages. White, this is spots, this is plasma exudates. Of course, if you have so high damage of eyes, no, patient experience problems with vision. Okay, this is other pictures. For example, this is normal retina, and again, this is retina of patients with arterial hypertension. Different bleedings, spasms, and so on. Remember I told you that arterial hypertension, this is very variable. And if we measure his blood pressure once, we don't know what happened with blood pressure during 24 hours. To reveal this, to detect this, we can use so-called ambulatory blood pressure monitoring. This is indirect automatic blood pressure measurement, can be made usually over 24 hours period using a measuring device worn by the patient. No, this is very simple. Small box which carried by patient, and this box measure blood pressure every time, 10 minutes, after 15 minutes. It depends on computer program. What we can get finally? We can get such charts, such graphs. This is very interesting graph showing what? You see, this is blue systolic blood pressure, red diastolic blood pressure. And this is points, this is measurements of blood pressure during 24 hours made by device. This patient, when he visited hospital, you see his blood pressure was extremely high, 180, and this is already third stage arterial hypertension. Start treatment immediately. But what happened then? When patient left hospital, his blood pressure normalized, you see, and the whole day it was normal, systolic and diastolic. But when patient next day went to the hospital to remove this device, his blood pressure again rise. And this phenomenon is known as white coat hypertension. It means when patient see a doctor, he becomes afraid, excited, and as a result his blood pressure rise. That's why, for example, this patient, he need no remedies, he need no treatment, because all his day his blood pressure is normal. Another chart, another graph, another patient also with high levels in hospital. But what ambulatory blood pressure monitorings reveal? That even during daytime his blood pressure remains higher than normal. Diastolic, systolic, it means that this patient, we must prescribe treatment. We must prescribe treatment to this patient. We prescribe treatment, and in 3 months we do this examination again, and what we see? When patient take pills, his blood pressure remains normal during the whole day. It means that we succeed. We can control his blood pressure, and patient can avoid all these serious complications I told you. What else? I told you that arterial hypertension leads to risks of dying from cardiovascular disorders. But not only arterial hypertension increase such risks. Together with arterial hypertension, there are different risk factors. I told you about this breakfast already. This is cigarette smoking. This is obesity. This is physical inactivity or hypodynamia. This is dyslipidemia, diabetes mellitus, age, family history of premature cardiovascular disorders, any chronic kidney diseases. You see, all these factors also increase probability of dying from cardiovascular disorders in patients with elevated blood pressure. If you have patient with damaged organs, target organs, with the damage of the heart, for example, left ventricular hypertrophy, angina, myocardial infarction, or brain damage, for example, stroke, or damage of kidneys revealed by decrease of filtration of urine. This is actually, all these lead to the fact that we have different risk groups of patients, For example, low risk group. This is individuals who are free of clinical cardiovascular diseases, target organ damage, and other risk factors. It means that patient has only elevation of blood pressure, but no other risk factors. No obesity, no smoking, no alcohol consumption, no damage of inner organs. And what does it mean? Only, first of all, this is only 2% of hypertensive patients fall into this low risk category. And why it's important to know that this is low risk? Because now we are planning what to do with such people. Low risk individuals with prehypertension or stage 1 hypertension may be treated with lifestyle modification alone up to 12 months. So again, we can avoid prescribing pills. We can just try to change his lifestyle to normalize his blood pressure. No, if we have moderate risk patients or even high risk patients, of course we must prescribe treatment immediately. We should prescribe medications immediately for such patients. What about lifestyle modifications? What patient can do? Remember about risk factors. No, for example, everyone knows that overweight leads to hypertension. You see, losing only 10 to 20 pounds, it means only 5-6 kilos, can lower blood pressure by 10 systolic, 5 diastolic. You see, decrease in weight can decrease blood pressure. And in some people, when they normalize his weight, his blood pressure also normalizes. That's why it's very important to force patient to decrease his weight. Moderate dietary sodium reduction. Also, if patient take less sodium, less salt, his blood pressure also reduced by 5 systolic, 2 diastolic. And what does it mean, low sodium intake? Actually, each product, vegetables, meals, meat, bread, already contains salt. Salt is everywhere. Salt present in all liver cells. That's why you need now to have separate salt on your table. That's why don't use salt additionally. And as a result, actually, if we are talking about patient with arterial hypertension, it may lead to decrease in arterial blood pressure. Smoking should be cancelled for sure, because smoking raises blood pressure. So that's why we should advise our patient with arterial hypertension, stop smoking, cease smoking, and it may lead to reduction of blood pressure. What else? Alcohol intake. Again, in France, in Europe, they tell that one glass of red wine is not actually harmful. And if it's more, okay, this is harmful. No, theoretically, it's easier just to say patient to avoid alcohol because it's difficult to control, to measure. And now doctors, they tell that no benign doses of alcohol, no benign doses of alcohol. That's what you should recommend to your patient with arterial hypertension. Stop drinking alcohol at all. What else? Exercising. Of course, we are talking about elder people. We shouldn't tell them that they should, I don't know, ride bicycles or running, jogging. It's just actually 30 minutes walk every day already can reduce blood pressure by 5 millimeters systolic, 2 millimeters diastolic hydrargyro. So just again, small aerobic exercises, just go to the shop, go back from the shop, and if it's 30 minutes, it's more than enough. So what is the goal of our antihypertensive treatment? The goal is to reach normal blood pressure. It means that blood pressure of patient should be lower than 140 by 90. Of course, we have a lot of remedies. You just imagine markets, 1 billion people markets who suffer from arterial hypertension, and don't forget that all these people, they should take these pills all his life, every day. That's why pharmaceutical companies produce a lot of remedies, antihypertensive remedies. Yeah? And what you should know about all these drugs. No difference which drug reduce blood pressure. The idea is following. If the cheapest drug, I don't know, diuretic, cheap diuretic remedy decrease blood pressure to normal levels, it's okay. You shouldn't try to use the most expensive, most modern drugs. The main goal, achieve normal blood pressure. Next idea, patient should take pills all his life. If patient stop taking pills, blood pressure rise again. So patient should take pills every day, all his life. Only in this case we can reduce blood pressure. Is it reachable? Yes, some examples show us, for example, United States of America. During last 20 years, they reduced two times mortality from myocardial infarction and stroke only because of strict control of blood pressure. Good treatment of patients with arterial hypertension can reduce number of people who are dying from cardiovascular reasons, from stroke and myocardial infarction. So that's what you should tell to your patients. Okay. If you have some questions, please write these questions in the chat. If everything clear, write that everything is clear, because we should see that you understand what we are talking about. So please write questions or write that everything is clear. And don't forget again to write your name and group number on the wall in Vkontakte, not in the chat. In the chat you should write your questions. Okay, any questions?